Hi, I am Dr. Felice Gersh, your integrative OBGYN, here to talk to you about the impact of menopause on sleep. Now, the first thing you may ask is, what is important about sleep? Well, it is extremely important. Sleep is very different than being awake. It's like a different metabolic state. Humans are diurnal. Other animals like rodents and cats, bats, they're nocturnal. So we are, like I said, diurnal, so we need to have sleep. During sleep, our entire system is different. We have a change in our blood pressure. Our blood pressure should dip. Our temperature should go down. Cortisol from the adrenal gland should go way down, and by 2 a.m. we should have a giant spike of melatonin. Even the gut microbiome is different during the night, and in fact, some species of microbes actually swarm, almost like insects. It's really quite different. Metabolically, they're doing different things in the gut. As well, we have differences in hormone production. Growth hormone is produced during the night. You probably heard, oh, kids grow at night. Well, growth hormone comes out at night. And the body prepares to make thyroid hormone during the night. And we have changes in other things as well. It's so important. Our immune system is different at night. During the night, our immune system is doing a lot of cleaning up. It's like different. And then in the first part of the morning, the immune system becomes much more pro-inflammatory, but not during the night. We have a difference in blood flow to our brain during the night. We have a giant blood flow, and the brain is like doing housekeeping. It's like clearing out the gunk from the brain. So we need to get sleep, and we need to get it every night, okay? Now, what happens as we transition into menopause? Well, the obvious, we have changes in those vital life hormones. Estradiol, the ovarian-produced estrogen, and progesterone. Well, we know a little bit about what happens during menstrual cycles, and so that gives us a little eye on what these hormones do regarding sleep. If we look at the luteal phase, that's the second half of the menstrual cycle that occurs after ovulation when progesterone is produced. Well, it turns out that many women have reduced sleep function in terms of sleep efficacy, quality of sleep, and it affects them sometimes with mood. Have you all heard of premenstrual syndrome, PMS? So it turns out that there is something going on in the second half of the menstrual cycle when progesterone is produced that seems to have a negative effect on sleep for many women. Well, what could that be? Well, it turns out that progesterone downregulates the effect of estrogen, and it reduces the impact of estrogen receptors. They become less functional. So perhaps in those women, and I have seen this, and it's not published, this is my own observation, that women who do have problems with sleep during the luteal phase do not make enough estradiol. So perhaps the progesterone is reducing the efficacy for sleep of the estradiol. And I have given women who have this problem some added estradiol, and guess what? They do better. By the way, this has also been shown to help women who develop migraines, the premenstrual migraines. So estradiol is really effective for sleep. So let's talk about what does estradiol do that makes sleep so much better. Well, we know that estradiol works to help women fall asleep faster, stay asleep through the night so they don't have multiple night awakenings, and that they don't wake up early, like too early, like 2-3 hours too early. That happens many times in women as they transition and spend the rest of their lives in menopause. So this may be happening to you. These are the very typical complaints about sleep that menopausal women present with. They have trouble falling asleep. They wake up multiple times during the night, Or they wake up, instead of when they need to get up at, say, 6 a.m., they wake up at 4 a.m., wide awake, and they cannot fall back to sleep. Or if they do fall back to sleep, it's almost at the time they need to actually get up. So they get up and the alarm goes off and they're really groggy. So it's really important to know that estradiol is a huge factor in having quality sleep for women. Well, why would that be? What does estradiol do that contributes to quality sleep? Well, it's complex, but it's really important that you know something about this. Estradiol is critically important for the production of certain neurotransmitters in the brain. Well, what about serotonin? Serotonin neurons exist in the brain, and they do not function properly in an absence of adequate estradiol. Now, notice I didn't say some other form of estrogen. I said estradiol. Serotonin neurons require adequate estradiol to produce and have proper functioning of serotonin. Now, serotonin is known as the feel-good neurotransmitter. It makes you calmer, more at peace. And what comes from serotonin? Melatonin. So if you don't make enough serotonin, you're going to have more anxiety, more depression, and you won't make enough melatonin. Melatonin is essential for having quality sleep. So already you can see the problem here. Not enough serotonin, not enough melatonin. Well, that's not all. What about acetylcholine? Well, in the brain, acetylcholine is also important for sleep and for creating memories. But what about in the peripheral nervous system, called the autonomic nervous system? Well, estradiol is critical for the proper functioning of the autonomic nervous system. Now, the vagus nerve is the part of the autonomic nervous system that controls the parasympathetic, sometimes known as the part of the autonomic system that creates rest and digest. It's where we should be normally, when we're not being attacked by pathogens like bacteria or viruses, or we're running for our life from a wild animal, or we've been in a trauma situation like an accident where we're injured. During those times, we should go into a sympathetic state, not sympathy like, oh, I feel so emotional for you, my empathy. No, sympathetic as S as in stress. But the normal state, the everyday typical normal state, should be with vagal tone, activated vagus nerve, and a lot of parasympathetic activity. The neurotransmitter for the vagus nerve is acetylcholine. If you don't have enough estradiol, as of course is the case in all women who are in menopause naturally, and it happens during the perimenopause as the estradiol production starts to go down, and of course has crazy ups and downs on the way down, so you don't make consistently adequate amounts of acetylcholine, so you're not going to have enough vagal tone. The vagus nerve is really important for calming and rest, and the neurons that connect from the vagus nerve to other areas like in the gut and in the heart, those also have other nerves that go back up to the brain. And the brain goes back and forth with the vagus nerve to have what we call bidirectional. And so we have signals coming from the gut, signals coming from the brain, and they go back and forth to one another. So when you do not have enough estradiol, you're going to have changes in the gut, because the gut microbiome depends on adequate estradiol, and you will get leaky gut. So you're going to have more inflammation. The inflammation will then trigger more activation of the sympathetic nervous system, less vagal tone. You're not going to have proper short-chain fatty acid produced by the fermentation by bacteria producing the product called butyrate that activates the vagus nerve. So you're going to have signals coming from the gut to the vagus nerve to the brain that are more pro-inflammatory, more agitating. So you can see it's like very complex. So you need to have all these neurotransmitters. You need to have vagal tone. You need to have the autonomic nervous system functioning properly. When you don't have enough estradiol, not only do you not have the rest and digest kind of component and emphasis in this particular talk about rest, you also have too much sympathetic, which is part of the autonomic nervous system. That's the stress response. The neurotransmitter for the sympathetic part of the nervous system is epinephrine and norepinephrine. They're the parts of the adrenergic system as well that increases cortisol. So you have all of these stress type hormones, and they can trigger, like epinephrine, norepinephrine, rapid heartbeat, palpitations, which can wake women up as well. And because they have too much sympathetic output, too much epinephrine, norepinephrine, and then cortisol, they will have more anxiety just from that. So we can see how complex it is. And estradiol is so important for making the proper neurotransmitters, for maintaining proper vagal tone, for rest and digest and sleep and melatonin. So without estrogen, adequate estradiol, you're going to have more difficulty falling asleep, staying asleep, and this early morning awakening. Well, it's also involved with the master clock, the circadian rhythm. The master clock, called the suprachiasmatic nucleus, is a collection of neurons that sits atop the optic nerve in the portion of the brain called the hypothalamus. Without adequate estradiol, the master clock, the word we use is drifts. So you have a dysfunctional circadian rhythm. Well, without proper circadian rhythm, you're going to have improper sleep as well. So it's really important that we do get adequate sleep and we have adequate estradiol, because otherwise our brain isn't really clear and we can have what's called phase dysfunction. So you can have the problem where the brain is not sure what time it is because the circadian clock is drifting. So where it really is 4 o'clock in the morning, the brain thinks it's 6 or 7 o'clock in the morning. So we have problems with our sleep phases when we don't have enough estradiol. So these are really critical things, all of which contribute to poor sleep. Now, as well, estradiol, as I mentioned, contributes to the proper production and function of serotonin. Without that, you're going to have more mood swings, which women, as they enter into menopause, even with no previous history, their risk of mood disorders doubles. If you had a previous history, it goes up fourfold. So people have anxiety. They can't shut down their mind. They try to go to sleep and they're worrying and they're thinking. Their brain is like so activated. So without adequate estradiol, there's more anxiety, trouble calming down so you can fall asleep. And to compound the problem, it turns out that when your estradiol goes down, the brain, of course, wants more, so it triggers higher production through the pituitary gland of the gonadotropins, luteinizing hormone LH and FSH, follicle stimulating hormone. Those two hormones go high when you go into menopause, and they actually trigger anxiety in and of themselves. So women have even more anxiety. So if they do wake up during the night, they have so much anxiety and their brain is going so fast, they can't calm down. They don't have enough melatonin. They don't have enough serotonin. So all these things contribute to so much sleep disorder. Well over half of women, like 60%, when they're in menopause, have significant sleep problems. In my practice, it seems more than 60%, but that's what the literature says. Now, what about progesterone? Well, you're not going to have progesterone either when you're in menopause. Progesterone itself has many benefits for sleep. It is neuroprotective. It helps to create more myelin, so it helps the brain to be healthier. And as well, some of naturally produced progesterone will be converted into another compound called allopregnenolone. Allopregnenolone is a natural antidepressant, and it increases the activation of GABA, the neurotransmitter that is very instrumental in sleep. So GABA increases and functions better when you have progesterone that creates allopregnanolone. Now, allopregnanolone does not bind to progesterone receptors, but there's a lot of data that it is very much a sedation type of a product, of a hormone, and that as well it is anti-anxiety and antidepressant. In fact, a synthetic version of allopregnanolone is on the market not too long for treatment of postpartum depression. So from progesterone comes allopregnanolone, which also helps facilitate sleep. Now, let's talk about giving hormones to women in menopause. We certainly support that, but what about how we give them and the dosing? Well, here's my thinking, and it's evolving. I want you to know my thinking on this topic is really in flux now. So I may be changing how I approach some of the really important decision making that goes on in how to prescribe and how to dose hormones optimally for postmenopausal women. And I'm trying to get some funding for studies because this is so important. We need clinical data. We can't just work abstractly or just look at what happens in a normal menstrual cycle. It's not going to be the same. There are differences. And no matter how hard we try right now, we can't recreate hormones in a postmenopausal woman that's going to be really the same as in a 21-year-old woman. But when we give hormones nowadays, many women are getting very small doses of estradiol. I've talked about this before. We need to give physiologic doses, but maybe we need to give them higher than even what I have been typically giving, because we know that in order to get optimal benefits, it's dose related. So when you give just a tiny amount, you're not going to get all the benefits that I discussed regarding the neurotransmitters and so on, and the autonomic nervous system. It's dose related. Everything is dose related, like exercise. How much you have in terms of exercise is going to affect the outcome. How many vegetables you eat, how many hours of sleep you have. Everything is dose related, including how much estradiol you give someone. The fear of growing the uterine lining has been instrumental in keeping, for most women, the doses prescribed of estradiol really, really tiny. You're not going to get the same benefits for the brain, for the circadian rhythm, and all these things. So we need to have an adequate amount of estradiol given through the skin, transdermally. And what about progesterone? The most common way to give progesterone, which is so easy, is to take it orally as a pill or a tablet or a capsule. The problem is when you take progesterone orally, and this is really on my mind now, I'm just telling you, I've been looking at some very tiny studies that no one pays any attention to that really brought this back into my consciousness as really important that we rethink this. When you take oral progesterone, it goes through what's called the first pass through the liver. A huge percentage of it, but it's variable from woman to woman, and not enough data is even on this. It's converted into allopregnanolone. Now, I told you allopregnanolone has its own set of benefits. It does not bind to the progesterone receptors, but it does help to facilitate GABA, and it's an antidepressant, anti-anxiety. That all sounds very good, but it's not progesterone anymore. It's allopregnanolone. It doesn't bind to progesterone receptors. So if a ton of it that you take orally of progesterone gets converted to allopregnanolone, what happened to our progesterone? We're not getting very much. So that can have its own set of issues. We're getting an unphysiologic. This is not physiologic. Normal women in the reproductive years don't have this huge amount of allopregnanolone. Basically, when we give the oral progesterone, we're giving like a sedative, like a sleeping pill, along with an antidepressant. Now, maybe that's good in some amount, right? Maybe it helps women because women are having trouble with mood and so on. But when you give these large amounts, you're giving it like a drug. You're not recreating a normal amount of progesterone or allopregnanolone. This is not natural. This is not physiologic. We need more data. I'm concerned that in older women, it might make them so groggy they increase their risk of falls or bad judgment because it really is sedating. Now, it's good for the brain. I don't want you to think it's a bad thing. It's just how much is too much, and you're not getting the amount of progesterone that you may really need, and it may not support the uterine lining. You may have irregular bleeding, and it's just non-physiologic. Remember, I'm a simple thinker. I want to replicate the hormonal environment that's present in young women when they're at their peak health and fertility. That's what I want to do. And giving oral progesterone is certainly totally different from that. It's important to know. So we have to think about other ways of giving progesterone, and we need to get research. We need to look at giving progesterone intravaginally, maybe even rectally, or through the skin. But we definitely and desperately need research. In the meantime, I'm not changing my prescribing habits, but I'm really thinking about it. And additionally, there was a small study done, and I believe it was 2023. And in that small study, what they showed was when there was no estradiol, the arteries were quite constricted. We call that flow-mediated vasodilation was kind of tight. The artery was constricted. When they gave the estradiol to achieve a serum level of little over 80 picograms per mil, the equivalent, they gave a 0.1 milligram estradiol patch, the artery dilated. The flow-mediated dilation was good. When they then added 200 milligrams of oral progesterone, which is standard, the artery constricted again. Now, many doctors are giving 100, but they're giving it every day. And then they're giving a tiny dose of estradiol. This is not physiologic. And remember, progesterone downregulates estradiol receptors. So the whole idea of that is to prevent growth of the endometrium, the uterine lining. But what are you doing? This is not physiologic at all. And you're still getting most of the progesterone that you're giving converted into allopregnanolone, which is basically like giving a sleeping pill. So is that giving you true physiologic sleep with the right phases and so on? I don't think so. We need to look into this. Another thing I didn't mention about menopause is that as soon as a woman is entering into menopause, her risk of developing sleep apnea and sleep disordered breathing goes up 2 to 3-fold. And that, of course, is another huge problem. One clue that someone has that is that they wake up with a headache, they're very tired, and they have to urinate multiple times during the night. Because when you have sleep apnea, you will have alterations of your antidiuretic hormones, and you end up actually diuresing, or like putting out urine much more than should be normal during the night. During the night, the bladder should actually not be filling. The brain and the evolution doesn't want women to be getting up most of the night going to the bathroom many times. So someone who's urinating multiple times during the night, that's a high clue, big clue, that they have sleep apnea. So that's really another important thing. So what am I suggesting? Well, I'm not going to go into, because we've spent a lot of time on this, what to do about herbals and sleep hygiene. We're going to talk about that, but not in this episode. But what I'm recommending, as far as when you go on hormones, first, remember, the first step in solving a problem is to understand and acknowledge the problem. We have a major sleep problem for a high percentage of women as they are going through transition into menopause and thereafter. We need to acknowledge this is a real problem. We need to understand that estradiol is undervalued as a key player in having proper sleep, having the ability to fall asleep, stay asleep, not wake up multiple times, and then wake up in the morning at the right time, not 2 or 3 hours too early. We have to understand the role of estradiol with neurotransmitter production, the autonomic nervous system, the vagus nerve, the circadian rhythm, the gut, and progesterone, which is also really important for its conversion into allopregnenolone, which can increase GABA. And progesterone itself is neuroprotective. But too much or too little imbalances between these hormones can further the problem of sleep. And when we give oral progesterone, it's really like giving a sedative, a drug, and it's not physiologic. And we're not sure how much is right. Should we be giving some oral, some through the skin or through the vagina? These are the questions we need to answer. In the meantime, what I am recommending for my patients is that they have enough estradiol. There has not been an emphasis on getting enough estradiol. People are so afraid, the doctors and the other healthcare professionals, of creating growth of the uterine lining and having bleeding, that they're underdosing estradiol. We need to give physiologic doses of estradiol. How we give progesterone, not so sure yet. Is oral the right way? Maybe not. But for now, I'm not changing everything I'm doing, but I'm researching it, I'm investigating it, so stay tuned. I may be changing what I recommend as far as how to give progesterone. But don't be afraid of estradiol. Tiny doses, they're not going to be adequate to get everything right for proper sleep. And adequate proper sleep is essential for quality of life and healthy longevity.